We're going live now. Yep,
Okay,
we're
okay.
live. Yep. Good evening, everybody. If you're watching again, welcome to another episode on the live chat series. And with me in the studio here is consultant neurosurgeon Dr. Douglas Emeka Okor, and we'll just be having a chat around the whole neurosurgery thing because a lot of people have been telling me I talk too much about health tech, you know, and so I decided to bring someone who is inside the clinical practice. Let it not be as if we are shading those doing the clinical work. I mean, mind you, I still do clinical work anyway. Don't mind the whole tech stuff. So, Dr. Douglas, welcome to the show, and yeah, I'll hand over the mic to you to give us a little background about yourself.
Okay, thank you very much, Kelechi, aka Dr. Ron. I know you prefer to be called Dr. Ron. I love first names. If you don't mind me now and again, I'll still call you Kelechi as well.
That's
My name
fine.
is Douglas. Yeah, my name is Douglas Emeka Okor. Most people always think I'm Igbo. People see me and then they start speaking Igbo. I'm like, no, I'm not Igbo. I'm actually Soko. I'm from Delta State, but my mom is Delta Igbo. So my mom is from Asaba. So she gave me Chukwu Emeka. So that's where I'm middle name. Actually born and bred in Benin, Edo State, previously Benjo State when I was born. Primary school, secondary school, university. I went to University of Benin, the great University
Yeah.
of Benin. Um, and then after that, I did my internship in University of Benin Teaching Hospital. And then for my NYC, I left all the way to Kaduna State. I was in like a general hospital, which more like somewhere between a primary, secondary school, a general hospital called in Saminaka, somewhere like 2 hours, 30 minutes from Kaduna city itself, town itself. And spent 1 year there, and then came back again to University of Benin Teaching Hospital. Did like a medical officer job. Was one of the pioneers as a medical officer in the HIV unit. Then myself and one of my other colleagues, Tony, we started the unit. And
Yeah.
spent like 18 months, 2 years there, and then finally left to the UK to pursue my dreams to become a neurosurgeon. I remember when I was in my fourth, fifth year in medical school, when I decided I was going to become a brain surgeon. When I told my friends, they all laughed at me. They were like, "Yeah, you don't look like someone who will be. You're not like one of the superstar. You understand? Very bookie people." In fact, I was always in parties, organizing one party or the other. So they were like, they all laughed at me. But yeah, guess what? So I got into UK 2006. By 2014, somewhere in 2015, I was inducted as a fellow of the Royal College of Surgeons, Edinburgh, neurosurgery. So I actually became a neurosurgeon. And I moved back to in the UK, and then finally moved back to Nigeria in May 2017. And I've been in Nigeria since then, fully practicing in Nigeria and based in Abuja, the Federal Capital Territory. And most of my work that I've done in Nigeria have been in the private sector. But guess what? Now in the public sector as well. So I'm now a consultant neurosurgeon in the Federal Medical Center, also here in Abuja. So in that case, I think that's me. You have any specific questions about me personally?
So why neurosurgery? Why not any other specialty? I remember then when we were still in med school, most of us read this Ben Carson's book. I can't remember the title, but the one where he always kept talking about doing hemispherectomies and all of that. But by the time we came out of medical school, the reality was different. So what happened in your own case?
Yeah, it just reminded me of this song, Black Men United. When I was a young boy, I had visions of fame. They were wild and they were free. But when I grew older, and that's all was it. So yeah, same thing as well. But keeping here, you're absolutely right. You know, when you grow older, you see the reality. You see that, oh yeah, having a dream and having a vision are two different things. But key thing is this. University of Benin Teaching Hospital, the University of Benin, where I trained, from the mid-70s up until when I actually decided I was going to become a neurosurgeon, not one neurosurgeon, not even one neurosurgeon. So I have always been an artistic person. From when I was much younger, drew Voltron comic, used to do lots of freestyle drawing, very good with my hands and stuff. So by the time I was in just finishing my MD, going to my fourth year, my clinical year and stuff like that, I decided I was going to be a surgeon. Okay, so but the question was now, I was struggling, what kind of surgeon was I going to be? And of course, because of that gap where there was no neurosurgeon, in fact, I went through medical school, nothing like neurosurgery at all. No clue about neurosurgery. No neurosurgeon giving us any lectures, nothing at all. Absolutely nothing. Understands what you're being taught and stuff like that. So it was that gap that made me say, hey, there's value here. There's value that can actually put forward here. So I want to be a neurosurgeon. So that's why I actually decided to become a neurosurgeon. And of course, like I said, Kelechi, aka Dr. Ron, they all laughed at me, my
friend. Well, that's quite interesting. Some of us, we shall just left the whole neurosurgery thing. We left it for you people. So let's move on to other areas that won't stress us.
Yes.
Because I know, though I was very interested in pathology, I think I started from orthopedics. I had back issues. I moved from ortho. Okay, let me move to pathology. I travel around this country looking for, residency spots in pathology. Nothing. I say, let me just gingerly follow my health tech, and I'm happy, But that notwithstanding. So looking at the life as in neurosurgeon now, I mean, what are some of the common conditions you guys treat? I mean, a lot of people don't know the extent of the procedures you guys do. Do you mind shedding some light on that?
So basically, neurosurgery as a specialty has moved in leaps and bounds. So, for example, if you look at from the 1950s till date, okay, significant inventions, significant progress has been made in neurosurgery, both in the developed economies and even in Africa, even in Nigeria. Yeah, there's some kind of stuff that we do that people will be like, wow. Okay, so what's neurosurgery? The specialty neurosurgery is all about looking after patients that have medical conditions that affect their brain, their spinal cord, their spine, and the nerves that supply the rest of the body. People might be wondering, you said spinal cord and you said spine as well. Okay, so they are different. So the spine is the bone itself, that bony structure that goes all the way from the base of the brain down to the tail area, the back. And that spine actually houses the spinal cord. It actually protects the spinal cord. So there are different things. So the spinal cord is a soft tissue that carries all the electrical signals into the rest of the body, while the spine itself is a bone that houses and protects the spinal cord. So a neurosurgeon looks after patients that have these medical conditions that affects these 4 areas I talked about, and they do surgeries. Okay, they actually operate on brains, spinal cord, spine, and nerves. Okay, they do surgeries. That's the key. So in terms of the issue of the prevention, the diagnosis, the treatment, mainly more than 85%.
Guess network challenges. We just hold on.
Can you hear me now?
Yeah, I can hear you. Your audio is bad. It's all right. Yeah. Yes, I can hear you.
Can you hear me?
Yes.
Okay, yeah. So I was just going through the motions and in terms of the prevention, the diagnosis, the treatments, especially through surgeries and rehabilitation. Okay, most of the things that they will do are around surgeries. And so one of the key mistakes people make is confusing a neurosurgeon with a neurologist. Okay, so a neurologist looks after patients that have medical conditions that affect their brain, their spinal cord, not spine this time, their spinal cord and nerves, but they do not do operations. They are the very intelligent people. They give drugs, do lots of investigations and stuff like that. Okay, so that's the difference between a neurologist and then neurosurgeon, but both of them are neuroscientists. Both of them deal with the brain, spinal cord, and all that. Conditions that we treat, so conditions basically that a neurosurgeon will treat are conditions that affect the brain and the spine. Okay, what kind of conditions that can affect the brain? Let's talk about the common ones that we know. Trauma, okay, and talk about things like road traffic accidents, the most common one, isn't it? We talk about falls from a height. We talk about contact sport and impact during contact sport. We talk about being assaulted, clubbed on the head, or a punch on the head, or something like that. Okay, so those kind of patients, you can have them presenting with mild symptoms or features, all the way to something really severe where they're actually having seizures, being unconscious and stuff like that. Okay, so neurosurgeons look after those who has been severely impacted by a severe head injury or significant trauma. Okay, those kind of patients roll into a hospital that has the capacity involved. Usually you get the critical care staff, the anesthetists coming to stabilize the patient. If the patient is unconscious, you might need to actually be intubated, where they put a tube down the windpipe, get a diagnosis by taking the patient to scan, to get the scanner, and then up to ICU. And the scan shows that there's something that needs a neurosurgeon to operate on. Of course, the patient is going to theater. Okay, so we operate on the brain, doing different things. Sometimes you can have a blood clot in the brain, a blood clot outside the brain, pressing on the brain. Okay, you can have those things. So that's one of these trauma. Okay, also you can have trauma to the spine as well. The spine is grouped into different components. The one in the neck is called the cervical spine. The one at the end of the neck to where the end of the rib cage is called the thoracic spine, and the one in your lower back, locally we call it waist. In your waist region is called the lumbar spine. You can have an impact on the spine at any of these levels and have trauma. Actually ends just after, just below the where the ribs end. Okay, the spinal cord doesn't go all the way to the end of the spine in the waist called the lumbar spine. Okay, so you can have trauma to all this. If you have significant trauma where you have a complete spinal cord injury in the neck, you can lose the function of your hands and your legs. If you have the trauma in the what we call the thoracic spine or the lumbar spine, you lose the function of your legs and your hands are spared. Okay, it just depends on where that trauma is. And as neurosurgeons, okay, because as neurosurgeons, we are spinal surgeons, we can actually do operations to actually fix the spine. And the surgeon has a complete spinal cord injury, but those patients, you still operate on them anyway if they need an operation, because you need to stabilize the spine so that you can start mobilizing them and do physio and prevent other issues from coming up, like bed sores, chest infections, urinary tract infections, and all those things. Okay, so that's true. Okay. Second thing, infections. You can have infections affecting the brain, the spine, the areas around the spinal cord and stuff like that. You can actually have that. Okay, you can have pus in the brain. You can have infection within the blocks of bone that make up the spine, what we call it discitis. Okay, so neurosurgeons get involved and do operations with that as well. Okay. Degenerative changes. Okay, you can have degenerative changes in the brain. Okay, where you have things like Parkinson's disease or and stuff like that. But there you have what we call functional neurosurgery, where you're putting in deep brain stimulators to try and control like some of the tremors, the dyskinesia, slow movements, and stuff like that. So that's really high level neurosurgery. In places like the US, UK, they do this kind of functional neurosurgery. In Nigeria, we are not there yet.
Well, hopefully very soon.
Hopefully very soon. But in the spine, you have degenerative issues. In fact, there is a significant number of people who have spinal problems have degenerative wear and tear, arthritis in the spine, and a significant number of them will actually need operations. And so we have neurosurgeons do this kind of operations as well. Also, tumors, neoplasms, cancer, tumors, neoplasms. Okay, there are different types of tumors. You can have benign tumors, i.e., that means they are not cancers. Okay, they're just putting pressure on the brain or the spinal cord, or somewhere in the spine. Okay, and then you can have tumors that are malignant, cancerous, aggressive, and stuff like that. Okay, in the brain, you have two types. You can have cancers or malignant tumors or aggressive tumors that actually arise from the brain itself, or you can have a tumor that spread from somewhere else.
Yeah.
to the brain. There are about 5 common places where tumors spread to the brain: the breast cancer, lung cancer, colorectal cancer, cell carcinoma, and from skin lesions, what we call melanoma. Okay, those are the common ones. So also you can actually have cancer spreading usually to the around the area around the spinal cord, not pressing on the spinal cord or the nerves. Okay, but the big medical term is metastatic epidural spinal cord compression, something like that. Okay, so this is just generally just gives you an idea of the kind of things that we do. Now, the key thing is that the brain, the spinal cord, and the nerves, they are all permanent tissue. Big words, but it just means that the way God for them to regenerate. Okay, unlike your skin ball. Okay, if you cut your skin, it regenerates very fast. If you cut your ball and put them together, it heals up very fast. But the brain, permanent tissue. That's why there's this adage that time is brain and time is spinal cord. The more damage you have to the brain and the more function you lose, it's difficult, especially for emergencies in brain and spine surgeries. There's the issue of time. We always say, hey, time.
Yeah.
Okay. After you do something, the more you can actually preserve function or relieve dysfunction. Okay. That's really the error for margin with what we do is so small, very, very small. And that's why sometimes people ask me, I say, well, how many years did it take you to train to become a neurosurgeon? Like almost a decade. I'm like, oh, that long? I said, well, yeah. You need to be really good at this. If not, you damage people.
Now, interestingly, like you said, what you guys do is very delicate, and considering the very delicate nature of neurosurgery. So, how do you balance the risk and benefit? I mean, in terms of a patient comes in, you're explaining, okay, it may go this way or go this way. How do you navigate that murky water?
So let me start this with Kelechi, aka Dr. Ron. See, so the key thing is that I was trained in UK, okay, in United Kingdom, okay, and so that means that in terms of the level, the competence, the experience, the exposure, and stuff like that, I have that from the UK, okay. Yeah. But now I've been back in Nigeria for 6 years, okay. So one of the key things is that what is the difference? How would I make a particular decision in the UK probably different from the way I would make it in Nigeria? Oh, there are definitely differences. There are differences. In the UK, for example, people are more educated. You have systems there that work when it comes to the issue of things like clinical governance, things like systems that work, the technology, the equipment that you need, the whole, in terms of the multidisciplinary approach and the way the system is organized. Okay, you don't have that in Nigeria, so it's a little bit of a struggle in Nigeria. Okay, now the key thing, okay, I don't know if it's a British trend, but the key thing is that first of all, you must always be safe. You must always ask yourself that question that what you just talked about. The family, I talk about putting things on a scale. Okay, yeah. You're putting things on a scale. If you do an operation for a patient, okay, every time you're doing an operation on the brain, the spine, or any operation at all, there are risks of possible complications with doing the operation. So the question is now, what is the benefit of doing this operation? Does the benefit of this operation far outweigh the risk? Okay, so that's the way I put it. So I always try and give some sort of figure. Okay, so for example, if I have a patient who has maybe wear and tear in the neck, and that wear and tear is causing compression in the spinal cord in the neck, and the patient is losing the function of the hands and the legs. In fact, I actually saw a patient today like that, and actually had this discussion with them. I tell them, hey, in terms of risk, let's look at the risk of what's going to happen to you if you don't do a surgery plus if you do a surgery. Okay? If you don't do a surgery, sir, you are definitely going to get worse, 100%, and you at some point you'll be in the wheelchair, you won't be able to use your hands and stuff. That's 100%. If you do a surgery, there's a 3% chance that I can have this complication. So 100% versus 3%. So, Dr. Ron, which one will you take? I don't think 100%. You know, so, and then also, so Nigeria has happened to Key thing is one of the ways I'm trained. One of the ways we are trained in the UK is to under promise and over deliver. Okay, so for example, I will tell a patient and the family that because your spinal cord is permanent tissue and it's difficult for it to regenerate, okay, I can see there's already damage to your spinal cord. What I can promise you 100%, there's not 100%, but almost 98% is that I can stop you from getting worse, because 100% you will definitely get worse. Okay.
Yeah. Absolutely.
Promise that you will definitely get better. I cannot guarantee that. Okay. But guess what? In reality, a significant number of them actually improve. More than 85% of them actually improve after I do such an operation. So generally, they feel elated and euphoric after that because I didn't promise them. Okay, which is different from what most people in this part of the world do. The average doctor in this part of the world will say, "Oh, don't worry, I'll look after you. You'll be okay. Don't worry," and stuff. And then maybe they do an operation and then the patient is not better. They're like, "Oh." So my strong advice is any practitioner is that it's better to underpromise. Always better. It's a better culture. Underpromise and overdeliver. You know, so you make patients and their families much happier. So in terms of how we actually make those some of those decisions, that's one. Another key thing has to do with culture as well, of the way people actually do things. So for example, if you have a patient who has a significant, what I call a catastrophic bleed in the brain in the UK, okay, and you know that, hey, there's no need to do any surgery in this patient because this patient is not going to do well. Okay, you explain that to the average family in a place like in UK and stuff, they understand. In Nigeria, it is difficult. They want you to just do something. Just do something. You understand? Even if you just scratch the head, you understand? So even when the patient passes away, they say, "Oh, at least we did something." So different cultures. Principles. I try and just modify it a little bit sometimes. Okay, so for example, I will never do a big surgery for a patient. Okay, if a patient has a massive bleed and maybe has hydrocephalus, I might just do a borehole and maybe just put an EVD in, but you won't see me. So it's difficult. It's difficult, different cultures and stuff. And then there's the issue, for example, in a place like UK, they understand what they call the dignity of the human being. Okay, so they understand that, for example, if a patient is in a help this patient, okay? Oh, we cannot insult this patient's dignity. We know this operation is not going to help this patient. So please leave the patient alone, okay? In Nigeria, anytime I talk about patient dignity, they all look at patient dignity. What is that?
What is this one saying?
What is this one saying? Okay. So the way you will make decisions, there are general way about making decisions. There are international best practices, there are global best practices and stuff like that. But one of the things I've learned over the last 6 years is that you try and domesticate it a little bit, okay? Looking at the way people actually rationalize things and the way the culture of the people are here. But generally, in terms of making decisions, looking at benefits and risks and weighing them and talking to the patients, generally that's an idea of how I at least do. I hope that my colleagues as well in Nigeria do it as well.
Do like that. No, I mean, again, looking at what you just said about some of the differences between working in the UK and working in Nigeria. So how do you approach patient communication? Because trying to make patients understand, okay, this is what you have, these are the issues, this is what's likely to happen, and all of that. Because again, I get that complaint a lot of times where people say the doctor did not even tell me what I have. They just say I should enter the theater, or mommy should go into the theater, and all of that. So how do you bridge that gap, patient communication and understanding?
Let me track back a little bit. 2007 was when I actually really started working in the UK. I started in A&E first. And around that period, every time we're doing anything, everything was communication skills. I got almost fed up. I said, what is this communication skills about? Everything communication skills. And then I got back to Nigeria, Dr. Ron. I was like, okay, now I understand the importance of these communication skills that you're talking about. When it comes to communication skills, Dr. Ron, we are struggling in this part of the world. It is almost practically non-existent. Okay, the truth is that healthcare professionals across borders, I'm not just talking about doctors, you understand, they lack it really, really badly. Okay, and patients and diabetes really, really suffer. In fact, for someone like me, I'm at the other extreme. In fact, a good number of patients and families actually take me as a very weird doctor in Nigeria because I communicate. In fact, they feel that I give them too much information.
Which is supposed to be the normal thing.
Which is supposed to be the normal thing. So remember, it's cultural. They are not used to that. They are not used to it. Doctor telling them all the details and stuff like that. They are not used to it. Especially, for example, when it's in a patient who is in a really bad way, a patient who is really, really unwell. Okay, a patient who is in a critical condition and stuff like that. Okay, that's really tricky. Okay, well, usually what I do is I get staff trying to have that multidisciplinary approach. Okay, get the anesthetic in the critical care patient, for example, get the anesthetist, get the ICU nurse, sit down with the patient, the family, make sure that everybody introduces themselves. Start with the family and someone say, hey, what do you know so far? Okay, they try and sort of give it, okay, we know that Mama had a bleed, they said she had a bleed in the brain. I said, oh yeah, I'll go and say, you're absolutely right. Mama's had a bleed in the brain. I'll try and do some anatomy. Okay, the bleed is somewhere here. Okay, whatever. It's very close to a particular structure in the brain. So I try and really break it
down.
Give them an idea of prognosis, okay, and stuff like that. Okay, if it's a patient that's not going to make it, that's catastrophic bleeds, clearly I know that this patient is not going to survive. I know it. So I use words like based on my experience and what I know, I'm looking at the way Mama or Papa scans are, looking at the way Mama's medical condition is now. Mama is going to struggle to make it. We're not giving up on Mama, okay? We'll struggle for Mama to make it. And the reason why we do that is to actually manage the expectations properly. It's really, really important. Okay, extremely important. So yeah, initially when I started out, for example, when I started with I was in the hospital at one point. And so initially when I'm communicating with patients, the nurses are taking about the way you just told them. I was like, yeah, you actually need to know. And what happens is that because I actually communicate with the family of this kind of critically ill patient like that, okay, it actually relieves the nurses of pressure. Okay,
yeah.
the relatives don't start jumping on and say, oh, what's happening, Mama? Oh, it's not going to survive. But because I've prepared the ground already, so even when we finally lose the patient, okay, they've been carried along. They already know. They already had an idea that this was going to happen already. So yeah, so even though okay, yeah, I've had to shift a little bit the way the kind of language I use and so I'm still when I Nigeria basically. Okay, global. I'm going the global way. So global best practices on. I'm looking at our special circumstances in Nigeria. So I'm in that locally.
Yeah. That's quite interesting, and I hope other physicians and surgeons follow suit too, because it's a recurring issue when I come across a lot of people say, why are your colleagues behaving like this? Nobody explains anything. The other day, somebody was saying, I think he or she was giving medications, but they weren't told the names of the drug, possible side effects. Say, just go and take this drug, come back, see us in 1 month, and that was the end. So she had to come back to me to start asking me, Casey, what's this? What does this one do? I was like, didn't your doctor tell you all of this? He said, no, they just told me to take and come back in 1 month.
But see, Dr. Ron, it's input determines output. Okay, how were most of the healthcare professionals in Nigeria?
Yeah.
The people they were looking at were they very good communicators. Okay, did they understand the importance of communication with patients? Okay, we're making sure that consent, giving a proper consent, making sure that when you're asking for blood tests, asking for any investigations, you're explaining what the blood tests are all about and stuff. You're giving medications, you're telling them when they were growing up as trainees or whatever, either at basic training or in their postgraduate training and stuff like that, did they see their seniors, their professors, their matrons? Did they see them doing it? Okay, so there's more of a systemic problem, not just about the individual who no. Okay, I came back from UK to Nigeria with a particular thank God. The key thing here is that culture is dynamic, isn't it, Dr. Ron?
Yeah.
These issues we're talking about can actually change. Okay, they can change with proper leadership and understanding that, for example, we need to recalibrate our training systems. Okay, we need to make our training systems more of competence-based. Okay, and look at the key issues of teaching, leadership, management, non-technical skills, and stuff like that. Those things we need to actually train, and all the way, not just at postgraduate training, but all the way from basic training. Okay, it has to be a lifestyle. That's what I'm telling you, Dr. Ron, that when I came into the UK, everything was communication skills. Because I was like, I was putting my communication skills. Very, very important. Also, for things to change, okay, it has to be multifaceted, multi-pronged approach. One of the key things we need to be doing is empowering the average Nigerian patient. Let them know that, hey, the doctor, the nurse, the physiotherapist, they are not doing you a favor. It is their job to provide care for you. And it is your job and your responsibility, okay, as a patient, to also ask questions. Okay, sir, you've given me these drugs. What are these? Which one is this, sir? This test you're doing, sir, what is it for, sir? Yes, you ask the questions. It's your right. It's your body.
Exactly.
Okay? Even if you look at the National Health Act, if you look at the National Health Act, everything is spelled out there. In the National Health Act.
Line by line, yeah.
It's spelled out there. It's a standing legislation. It's a law in Nigeria. Okay? One of the key things that people just need to know is that know your rights. It's only called the Patient's Bill of Rights. Everybody should go read it up. And the nurse, the doctor, they are not doing a favor.
Absolutely. Then another thing I wanted to ask was, so how do you keep up with latest trends in neurosurgery? Healthcare is changing very rapidly, and doctors are very busy. So how do you manage to squeeze that in?
Okay, so good question. So the key thing is that, remember, I was trying to give you to sort of describe the difference between the level of what we are practicing in neurosurgery in Nigeria and the level in places like UK and US and stuff. Like when I talked about, for example, something like functional neurosurgery. Okay, so functional neurosurgery, for example, will entail things like epilepsy surgery. Okay, entail things like deep brain stimulators. Okay, for Parkinson's, for example, of patients who have things like essential tremors, okay, and stuff like people who have dystonias. Low back pain and stuff like that. So a spinal cord stimulator is at the top spectrum for pain management. Okay, things like intrathecal baclofen pumps, intrathecal morphine pumps, where you're actually putting a pump, okay, under the tummy and then connecting a tube, a small catheter into the spinal region to actually deliver either morphine or baclofen, who has spasticity. So that's really high level, isn't it? That's high level. Now, for example, I spent 1 year in Liverpool, and in that 1 year, I was doing functional neurosurgery. While I was there, I was just like, hey, I'm just wasting my time here. I'm not going to use this in Nigeria at this particular point in time. For the next 15, 20 years, Nigeria is not going to need this. Okay, functional neurosurgery, the number of patients, neurosurgical patients that need functional neurosurgery are maybe less than 3%, less than 2%. Okay, so sometimes you actually need to look at the realities of where you are. And so when you talk about the latest technologies and stuff like that, okay, with respect to what? Okay, in Nigeria, you're struggling with basic equipment, and then you now want to go and start getting one high-falutin equipment. No, so one of the things that I don't waste my time going for some kind of high-falutin courses and stuff. No, I stick to real life stuff. Okay, and guess what? With the internet and the social media and stuff like that, okay, when I'm doing I do very complicated cases in Nigeria, really the kind of stuff people do not believe we can do in Nigeria, we're actually doing them. And usually when I have a complex case, what do I do? I send messages, scans and stuff to my colleagues in the UK and US, and then I go on YouTube and watch videos and listen to people. Now, the key thing is that because I'm very well trained and I had that basic fundamental training for doing complex neurosurgery, there are surgeries that during my training I didn't even do, but now I can go anywhere in the brain, in any corner or in any corridor of the brain. Okay, Like there's a video that I released recently of where I did an interhemispheric, as in going in between the two hemispheres. Okay, translaminar terminalis. The laminar terminalis is just in front of the third ventricle, just on top of the optic nerve and optic chiasm itself. Okay, and it's not like I've been doing that all the time, but I just watch it on TV and stuff like that, on YouTube and so I say, okay, do this, all key things to look out for and stuff like that. Okay, go in, came out, case done. Okay, so in terms of keeping updated and stuff like that, it's just, you understand, using social media, using internet and stuff like that. Earlier on, maybe like the first year at what I came out, I went for a few courses and stuff like that. But by the time I had spent some time in Nigeria, I was like, okay, you understand, we are even struggling with the basics. Okay, maybe at some point in the future I'll go for some courses, some maybe complex call, because I'm actually a soft specialist in skull base, so I actually do skull based stuff. I also use the endoscope also through the nose, so what called endoscopic transnasal transphenoidal. Okay, and then I'm a neurovascular surgeon, so all the aneurysms, they bleed from aneurysm, clipping the aneurysms. So if you watch some of my videos, you see where we actually
I've seen a couple of them.
Exactly. Then I do complex spine as well, the whole range of complex spine, except deformity surgery. Okay, I don't do deformity surgery. Most of the time, the orthopedic guys who actually do spine, they are the ones who actually do deformity surgery. So an example of deformity is scoliosis, bendy spine. Okay, so I don't do that, but every other thing in complex spine, I do cervical, thoracic, lumbar, and I do. So yeah, so those are some of the basic differences. So even when I'm talking about keeping updated and stuff, it has to be relevant to my environment.
What you're doing at the moment.
That's that's really, really, really important. I'm sure in the next 15, 20 years, we'll scale up, but you must get your foundation right first. That's really, really important.
So I can now build on that as time goes on.
Absolutely.
So somebody sent me a DM. He said he's asking a question. Do you regret moving back to Nigeria?
Good question. I always wanted to come back to Nigeria. Before I left for the UK, my plan was to come back to Nigeria. Okay, it's been a sweet, bitter, sour experience all rolled into one. Okay, number one. Okay, I'm sure if I move to the Middle East or I move to Canada or stuff like that, I'll be richer. Definitely. Yeah. Okay, I'll be richer. But guess what, Dr. Ron? Look at the kind of cases I do. Just watch my video and see the kind of really complex. Do you know that even my colleagues in the UK, when they see the kind of cases that we get up to in Nigeria, they're like, wow. Anytime, because of course I train mainly in Royal Hallamshire Hospital in Sheffield. Anytime I go back home and I stroll into the hospital and go see my colleagues, my consultants, they're like, wow. It's almost like a red carpet greeting. Yeah. You understand? Okay. Whether you like it or not, yes, is it? I look much darker. I was much fairer than this. I was a fine boy. Look at me now. Look at what Nigeria has done to me. But guess what? I'm proud, very proud of what I've achieved. My presence here has raised the bar and standard of what we do here. I'm telling you the truth. Okay? I'm telling you the truth. In life, you need some people to lead. Okay? Yeah. I'm just one of those people. You just need people to lead. You understand? And build that bridge. Okay, I'm just one of those people. So, do I regret? No, I don't. I'm very passionate about reforms in Nigeria. I'm very passionate about showing the whole world that, hey, you guys, you want to look down on us, but no, we can do big stuff here in Nigeria. People with little stuff, people with little resources. Okay, we can do it if we just put our mind and our heads in the right place. You understand? Work together and work properly. Have the right kind of mindset and so we can make miracles happen. And guess what? Touch wood. We're already making miracles happen.
Yeah, we are.
We are. And guess what? I keep telling you, I don't talk about, this is what I can do. I show you what I've done.
Yeah, the work speaks for itself.
Because one of the key things we need to do is we need to inspire ourselves again. We need to start motivating ourselves. One of the key problems is that we've lost faith in ourselves. We need to start recalibrating and start really motivating ourselves again. And guess what? When you see from Nigeria, hey, Nigeria, neurosurgery in Nigeria, clipped aneurysm, the patient is actually alive, complex brain tumor, in hidden parts of the brain, you went there, you took it out, patient's vision is better, headaches are gone, patient is walking around, you can actually see the patient walking. Wow, in Nigeria, initially when I started posting videos, some people were like, nah, This are you sure this is Nigeria? No, I'm not sure it's Nigeria. That's how bad. Okay, and of course, one of the key things I learned very, very fast, okay, was that yes, a good number of my colleagues, and there's nothing wrong with that, they like going to talk about their stuff that they do in their conferences, they also publish them in their papers, but guess what? Read your published paper either, okay? There's nothing wrong with, we should continue to publish papers. We should continue to actually gather in our conferences. So, but we must put the word out there. We must inform Nigerians. We must educate them. We must do health promotion. We must let them know that, hey, lots of things are wrong in Nigeria, but there are some good things that are happening as well.
Yeah.
To let them know. It's really, really important, Dr. Ron.
It reminds me of, was it 2 months back, when Aproko shared his video about, I think it was December, yeah, he was battling a tumor in his brain all through, and Dr. Ojo in Lagos.
Yes, my friend, Dr. Ojo. Very capable hand in Lagos.
Yeah, so it was really exciting, and then a lot of people were like, wow, so Nigerian surgeons can do something like this, So it was.
In fact, guess what? In fact, the latest video I just put out was exactly the same kind of tumor, even more complicated. Than that case. The latest video I put out. This was a lady in her early 50s. She was losing her vision. She had really bad headaches. She was becoming really unsteady on her feet. She had developed fluid pressure in her head, what we call hydrocephalus. And guess what? This tumor was banged in the middle of the brain. In the middle of the brain, you take ventricle. And when I looked at this camera, I was like, hey, what am I going to do with this? For almost 1 week, I wasn't sleeping. You asked me, well, how do I keep updated? I was watching one video to the other. You were talking to colleagues and stuff like that. Oh, what do we do for this? This one say, oh, no, take this particular route. The other one say, oh, no, take the route from top here. Oh, no, take the route. Oh, go through the nose and stuff like that. Before I finally decided to actually go through one. And guess what? Almost complete resection of the tumor. Most of the tumor that was blocking that water space, like cutting all of them out. I just left a little bit of what we call the pituitary stalk. Okay, so that the woman doesn't run into very big trouble with hormonal problems and stuff like that. And guess what? It's very well today. In fact, if you watch that.
In fact, after this session, I'm going to watch
actually talking about what his experiences, in terms of the team looking after his sister and stuff like that. So fantastic stuff happening in Nigeria. My friend and brother, Dr. Taiwo Joe in Lagos, doing an absolutely fantastic job as well. Okay, one of the key things you will see when I actually put videos out is that, hey, Nigerian neurosurgery is going places. Complex brain surgery is happening in Nigeria. Complex brain surgery is available in Nigeria. Okay, I never ever talk about myself that, oh, I'm a neurosurgeon. No, one of the things I'm trying to promote is that things are happening in Nigeria and things can happen in Nigeria. We can definitely make magic happen. Because, like I always say, my mantra: the Nigerian patients are worth it.
I was even going to come to that. The Nigerian patients are worth it.
Yes, exactly.
Your famous hashtag.
Absolutely.
Then, another issue is the issue of burnout. I mean, do you experience burnout, considering the fact that we don't have a lot of neurosurgeons in Nigeria, so, and I guess the workload is crazy. So how do you navigate that?
I wish the workload was crazy.
So it's not even crazy.
I wish it was. Okay, let me explain. I'm talking from a personal point of view. Okay, generally, as a neurosurgeon, naturally your workload should be crazy. Okay, but for me personally, remember when I came back to Nigeria 2017, I was in the private sector. Okay, private sector is private investment with equipment and stuff like that, and it's not going to be cheap for the average Nigerian. In Nigeria, 133 million multidimensionally poor people. Most of them cannot access that kind of care. Okay, and the middle class people, upper middle class people who can access the care are like, are you sure? Okay, so you're having a shortfall in terms of people there. And then at least I've been in the public setting since January last year, okay? And you know how the public setting is. We are still struggling to actually get the right kind of equipment to actually do the kind of big surgeries I do. Most of the big surgeries you see, I do them privately, okay? one of the key things I'm passionate about is actually providing options for patients. Okay, patients who are not too great, who cannot come to the private sector, you look after them in the public sector. We are not there yet. Okay, we are hoping that in the next couple of months or so we can start actually getting the hardware, things like the high-speed drills, the operating microscopes in Federal Medical Center. Okay, it's looking like we will get them. So I'm praying that we can actually get them. So we can actually start getting more cases done. And so when it comes to the workload is not that great at this moment. Okay, in terms of the numbers. Okay, but we are hoping that very soon, yes, we'll start building them up. Especially now that in the private sector. In Federal Medical Center, we have 3 neurosurgeons now, 3 consultant neurosurgeons.
Okay.
So that's where we are. So burnout, me, I'm a jai guy, and I'm a funky guy. I hang out. I love singing. I love dancing. I swim. I go hiking. I do camping. Okay. In the last couple of years, I've not done lots of hiking, security situation. Oh yeah, I'm someone who likes to enjoy myself. That's why I work hard.
And you play hard too. That's quite interesting. So what advice do you have for people who are aspiring to be neurosurgeons?
Nigeria has happened to me.
Yeah.
Can you hear me?
Yeah, I can hear you. Did you hear my?
Sorry, I thought you were going to ask me a question. I said Nigeria has happened to me, so let me come closer so at least you can.
It's fine. We can still see you.
Yes.
So I was like, what word of advice do you have for young doctors who are considering neurosurgery as an option, in terms of specialization?
Surgery is a technically challenging specialty. It also needs people who have strength of character. Okay, people who are, should I use the word long suffering, that can make sacrifices. Yeah. You understand? During my training, I made lots of sacrifices. It was not easy at all. I went through the mill. How do you create steel? Steel is stronger than iron, isn't it? How do you create steel? You have to put it through fire, isn't it?
Yes.
So I went through fire. Some people think when they look at me, they say, 6'4", fine boy. You understand? They think I just went to the UK and say, man, and I say, hey, look at me, I'm a fine boy. Maybe I went through the mill. And I tell people sometimes, because me, I'm not like the average doctor. I'm always wearing t-shirts, folding my sleeves, wearing jeans, skinny jeans, wearing cowboy boots and stuff like that. So initially, when I came back to Nigeria, they were like, are you sure this is a neurosurgeon? And I told them, I said, I'm actually trained very, very well. I'm actually really good at what I do. So the key thing is that it's something that you actually need to decide about and be ready to make the sacrifice, have the strength of character.
Yeah.
It's not for the soft-hearted or for the faint-hearted neurosurgeon. I won't lie to you. It is not. It's not. But also, I would say it is very doable as well. It's very doable. And there are different ways that you can actually get there. Okay? One of the things that you need to understand, if you want to actually go into a place like the UK or the US and get into their system there, it's extremely difficult. And the reason is just simple, especially from Nigeria. Okay? It's just simple. Okay, when to a medical school in America or in the UK, if they want to do neurosurgery and you come from Nigeria, you want to do neurosurgery with your going to Unilag or Uniben or UI, okay, and you come with your Nigerian passport and both of you are competing for neurosurgery. Common sense. Who's going to get it?
The other guy.
Okay, so that's why I mean Nigerians you see going to UK that are training to become neurosurgeons in the UK. Very few, isn't it? Most people are either doing GP
or psychiatry.
Or psychiatry or something else, isn't it? So that's why. But there are other options that you can actually follow as well. Okay, I don't know if type timetable, but you can actually combine, for example. Yes, and doing some. They will let you train, okay, by the side and stuff like that, and they can even sign you up for your fellowship exams, and you become a fellow of the Royal College of Surgeons as well. Okay. The key thing, I keep telling you, the key thing is to make sure that you're properly trained. Make sure you're properly trained. I was properly trained. Okay. Proper complex neurosurgery, even in Nigeria, especially in Nigeria. So
yeah.
I think in a nutshell, that's the advice I will have for young people, young boys and girls, ladies and gentlemen who want to become neurosurgeons.
Are there opportunities for people to, doctors to, come and observe procedures, your place and all of that,
Oh yeah, definitely, definitely, definitely. Anybody who wants to do that, but the key thing, like I said, for now, the turnover is not that high.
Yeah.
It's not that high. I've told the reason why. Okay, on one hand, in the public sector, things are not where we need to be now. We are really hoping, we are pushing for things to happen so we can have more numbers. In the private sector, hey, how many people can afford?
Yeah, those are the issues, really.
Yeah, big issues. So if I, usually when I'm being interviewed or when I have discussions, I don't talk about these things we're talking about, neurosurgery or what kind of thing. No, I actually talk about health reforms. That's what I'm
Yeah,
passionate
health
about.
reforms, exactly.
Yeah, so that's what I'm passionate about. I'm passionate about the bigger stuff. Yeah, I do my own stuff as a specialist. So I'm at the top of my game as a specialist. But I'm more interested in, okay, how can this stuff that I do that only few people are benefiting, how can we make it happen at a larger scale? Okay,
Scale it up,
I'm
yeah.
really, really interested in that. Yeah, absolutely. Mm.
And I really hope we get there very soon, It's
I hope so too, my brother, Dr. Ron. I hope so too. I hope so too.
Niger Wahala is a lot, but step by step, everybody playing his or her own game.
I know the thing is that Dr. Ron is not one of the cards that is on the table giving up. Okay.
Exactly.
And key thing, all our folks in the diaspora and stuff, like I know some people are not very happy with the way the last elections went and so on. And I keep hearing things like, oh, I've given up on Nigeria. Sorry, brother, sister, you cannot give up on Nigeria. Till tomorrow, Nigeria is your brothers, your sisters, your mother, they are still in Nigeria. And anything that happens in Nigeria affects them. Okay. I remember one time one of the UK Nigerian doctors groups, somebody was made a statement that Douglas, you've given yourself a very big task of going back to Nigeria. I hope you succeed. And my response to him was, I hope for your sake that I succeed as well. For your sake. Because the key thing is that people, Nigerians in Canada and UK, Australia, they always think that what's happening in Nigeria is not affecting them. Until one day their father has a stroke, or their father has a bleed, or a subarachnoid hemorrhage from an aneurysm or something, and guess who they call? Who do you think they call, Dr. Ron?
You are the one that we call
No,
now.
there you go. So can you see that for their sake that I succeed?
Exactly.
Mm.
That even reminds me about I think you're involved with this what they call them, the DFC, Doctors for Change.
Yeah, Doctors for Change.
Yeah.
Well,
What do you guys
it's a
actually
group.
do?
I'm part of the group.
Okay, 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 okay.
It's a group. So it's a group of Nigerian doctors who are in the diaspora, who have definitely been in diaspora at one point, okay, or are still in diaspora, and a good number of them are back in Nigeria or flow between the diaspora and Nigeria. So it's just a group where we all brainstorm, look at issues, and then finally we actually came together and did our first convention, talked about different issues within healthcare. They invited me to give a talk. They were like, "Oh, when you come around, you stimulate you make the whole place jiggy, bring some swag to the place." I was like, oh, who am I to refuse? So we had some discussions there. I think the present commissioner of health of Lagos was also invited as well to be part of
Yeah,
that.
Akina
So yeah,
Bayomi, yeah.
yeah, absolutely. Yeah. So yeah, it's a group. It's a group that has the potential to actually support. If you have a good government that comes into play, and because the truth is that to revamp, redefine, reform our healthcare system, you need the healthcare professionals of the diaspora. They must and get to where we need to get to in healthcare in Nigeria in terms of looking at issues of safety and quality, okay, without the diaspora healthcare professionals. Okay, the
Yeah.
diaspora generally. In fact, you cannot even develop as a country to the point where we can be proud and say, hey, yeah, we've done a fantastic job in terms of developing our system without the diaspora. Very important.
All right, that's fine because I know for a while I've been following what your activities, your conferences, and I speak with
Mm.
Dr. Biodun once in a while, of brain and
Mm.
spine surgeon. So yeah, it's
Yes.
interesting.
Mm.
All right, thanks so much. It's almost 1 hour. I mean, this conversation
Ah, there you go. We've been talking for that long.
it could go on and on, but I'll have to let you go at this point in time.
No problem. Let me find a way to a better hotel. They are trying to kill me nowhere.
No, don't worry, they will sort you out.
Oh yeah, yes. Where is your place, Doctor Rock? You guys are trying to kill me.
I'm not the owner of the hotel. All right,
Thank you so
thanks
much,
so
Doctor
much
Rock.
for your time. And
Thanks.
yeah, anybody that wants to reach out, I guess they can reach out to you.
No,
Um,
definitely, definitely,
okay. Are you very
definitely.
active on Twitter? I don't know.
No, no, I'm not a Twitter guy at all. I know some people like Twitter, but I'm not a Twitter guy. I'm more of WhatsApp, occasionally Facebook, but I'm more of WhatsApp and LinkedIn,
Yeah, so it's
and
easier to
then
catch
and
you on LinkedIn,
occasionally
right?
Instagram.
Okay,
Sorry.
okay. It's okay to catch you on LinkedIn, right?
Yeah, LinkedIn. Oh, yeah, definitely. LinkedIn.
Yeah. So anybody who wants
I'm
to
I'm
reach out to
LinkedIn.
yeah, anybody you can always reach out to him on LinkedIn, and his DMs are always open to whatever queries you might have and all of that. So once again, thank you, Dr. Douglas, for this interesting 1 hour, and yeah, we'll see you again maybe some other time, I guess.